Hey everybody, it's Cherry again. Just wanted to visit with you briefly. I say that, I mean it this time, about the types of shock. Shock in a nutshell can be just a little bit overwhelming, a little bit confusing, and there's two aspects of shock that we're going to look at. So I want to see if I can make this very simple and very clear for you. Okay. First question that begs to be asked is, what is shock? And so for all intents and purposes of this topic, and for what we're going to do as EMTs, shock is the lack of oxygen to the cells and the tissues, okay? If that's happening and the cells do not have enough oxygen, then we know they can't produce energy, we know they can't do their job, we know that they will produce lactic acid, and we know acid is bad, and that's going to cause a whole cascade of very bad and potentially deadly things to happen to our patient. Okay? So we're going to term that hypoperfusion if we want to look at the medical term for shock. Hypo meaning not enough of, perfusion refers to getting oxygen to the cells. Okay? So if we don't have enough oxygen going to the cells, we are going to have hypoperfusion, or we're going to call that patient and diagnose them to be in shock. Okay? Now, a couple of different aspects of shock that get a little confusing. First one is the stages of shock. This means, how bad is it? Are they just starting into it and they're still doing okay, or are they not? Okay, we'll talk about that in 1 second. The other aspect of shock that we need to consider is the type of shock. And this simply refers to what is causing it. Because unless we can figure out what's causing it, we don't stand a chance of being able to fix it. So we need to know, how bad is it? How much time do we have? And what is causing it? Because we got to fix this. Okay? We all know that shock kills people. So let's jump on these two things because it's going to help us be better clinicians. So let's talk about stages of shock first. Okay? One word. Okay, it's technically two. Okay, blood pressure. We know, based on what we know about pathophysiology, that we have to have an adequate blood pressure in order to have enough pressure to push those red blood cells through the vessel to deliver that oxygen to the cells. We can have all the oxygen in the world stacked on that red blood cell, but if we can't move it to the cells in the body, it's not doing any good. And it's the blood pressure that moves that red blood cell. So for all intents and purposes, we're going to say 90 systolic is that magic number. If we've got a pressure above 90, then we know we have enough pressure to move oxygen to the cells, specifically to the brain. Okay? If it's below 90, we don't know if that's enough to get the job done or not. So when we look at this, we're looking, there's technically 3 stages of shock. Okay, we're going to look at the first 2. Compensated, which means the blood pressure is adequate and we can move the blood to the cells. Now, a bunch of things have to happen. We have to have the heart working well. We have to have the vessels the right size. We've got things, the body's working harder in compensated shock to make sure oxygen gets to the cells. The point is, it's getting it done, okay? If our body can maintain a blood pressure, that means the cells are functioning. It means that we have enough pressure to move that oxygen around. Things are good. The second we start to lose that blood pressure, or it falls below 90, then we're no longer able to compensate, or our patient isn't. Okay, we are looking at a patient then that cannot for sure get oxygen to the cells, which means we're going to have a whole cascade of bad things start to happen. We're going to have cells start to not be able to produce energy because it requires oxygen to make energy. We're going to have cells that are starting to produce lactic acid. And we know that lactic acid is bad. Okay, acid is always bad. Lactic acid is really bad. So when that starts to happen, we're going to have cells that start to deteriorate. We have cells that break down. We're going to have capillaries that start to break down. It's just going to have this whole cascade of bad things start to happen. So look at your blood pressure. If your blood pressure is maintaining and it's above 90, we've got a little bit of time. If that blood pressure is on the decline, or if it's below 90, your patient is in decompensated shock and they are in serious trouble. Okay. So the other thing we're going to look at is types of shock. Now I'm going to come back to this one. I just want to briefly overview this and then we'll come back and look at it. Okay. So there's like 4 major types of shock. So cardiogenic, which means simply the heart is not functioning adequately. That's the cause. Okay. There's another type of shock called hypovolemic, which means for whatever reason, we don't have enough blood volume in the vessels. Okay. So you get this? We're looking at what the cause is. Okay. There's another classification of shock called distributive. And there are 3 different things that may cause this, but basically it means the vessels are too big. They're not constricting like they should to be able to help keep the blood pressure up. So distributive shock means the vessels are too big. And then the last one is obstructive shock, which simply means something is blocking the blood flow. Now, does it make sense? If the blood flow through the body is not adequate, then it can't pick up oxygen and it can't deliver oxygen to the cells. Now, this is not the same as cardiogenic. Cardiogenic is specific to the heart is the problem. Obstructive is something else that's causing the blood not to flow. We'll talk about that shortly. Okay. So one thing I want to make real clear is the signs and symptoms of shock happen when that sympathetic nervous system is activated. This is going to happen in all types and in all stages of hypoperfusion or shock. So the things we see that happen when that fight or flight response is activated, we're going to see the heart rate go up. Okay, that's part of how we compensate. Okay, we're going to see the respiratory rate go up. Okay, that's to make sure that there is ample oxygen available to the red blood cells. The high heart rate is going to make sure that we're moving that oxygen around as quickly as we can to get it to the cells. And then we're going to see pale, cool, damp skin, which is a sign of vasoconstriction. We're seeing that blood, the blood flow through the skin specifically, be shut down so that the body can shunt the blood to the core and keep the oxygen supply adequate to those vital organs. And because the blood flow to the skin is not as good as it normally is, our skin's going to look pale, it's going to feel cool, and because our body's working super hard, that sweat glands are going to be activated to cool our body down so we don't overheat. Okay, these are the classic signs of shock. There are other signs that are specific to the different types of shock. Okay, so when a person first goes into shock, you're going to see these things happen. When they move to decompensated shock, we're still going to see these things happen. The point is, they're no longer enough to keep the blood pressure up. Okay, so if we see this, we're like, yes, our patient is in shock. Then we've got to do 2 things. What stage of shock are they in? How bad is it? And what's causing it? What type is it? Let's talk about those. Okay, so that first one we talked about was cardiogenic shock. Okay, this means poor heart function. Some signs and symptoms you're going to see with cardiogenic shock, in addition to the tachycardia, the increased respiratory rate, not necessarily work of breathing, but the rate itself will go up, and the vasoconstriction, so that pale, cool, clammy skin. In addition to that, if this is cardiogenic, the cause is the heart function itself, we may see crackles or sometimes that's called rales, same lung sound in the lungs. We're going to hear water in the lungs. Okay. Crackles are a very tiny sound. They're hard to hear if you don't know what you're listening for. So I encourage you to listen to some lung sounds and learn to identify that one. Okay. We're going to hear that because if blood backs up from the left ventricle and it backs up into those capillaries around the lungs, then the pressure in the capillaries is going to get higher than the pressure outside the capillaries. And because the body is always trying to maintain homeostasis, we know that the body is going to shift fluid to even out pressures. So because the fluid is higher in the capillaries than it is in the alveoli, that water is going to move out of the vessel into the lungs. That's going to give us wet lungs. It's also going to give your patient water in their lungs, which in essence means they're drowning. Okay, this is going to keep the oxygen gas exchange from happening into the red blood cells. It's going to make your patient work hard to breathe, and if we don't get it fixed, it will kill them. Okay. Another thing we may see with cardiogenic shock in your patient that's sitting up, we will see JVD. Okay, and that is blood backing up into the vena cava and into the superior vena cava, which is your JVD, and the inferior. Now, if blood backs up into the body because of the inferior vena cava becoming loaded with blood and the pressure going up, we see that water move into the tissues, and then it sort of, by the function of gravity, settles in the lower portion of the body, which typically is the ankles, and we see that pedal edema. Okay, so those are three classic signs of heart failure: crackles, JVD, and pedal edema. So if you see those, start thinking heart failure. Okay. Hypovolemic shock, remember that's low blood volume, can be kind of dissected into two categories. Hemorrhagic, which is much, much more prevalent, is simply bleeding, hemorrhaging. Okay, this should be your number one consideration in every trauma patient that's showing signs of shock. So if you're seeing that pale clammy skin, high heart rate, high respiratory rate, look for signs of external bleeding. If you see it, stop it. If you don't see external bleeding, then we're going to have to start considering the fact that this patient may have internal bleeding. Okay, so in the case of shock, in a trauma patient, hemorrhagic hypovolemic shock is my number one possible cause. Okay, in some cases, we may see non-hemorrhagic hypovolemic shock. Okay, this is typically due to dehydration. Okay, and this can come from a lot of different issues. Typically, we're not going to see this in our trauma patients. I'm not going to say never, but we see this in emergencies like runners that are running in a marathon, and all of a sudden we get there. So what I'm looking for, if somebody's working hard or they're in a hot environment, I should see sweating. So if I don't see that, I'm going to look at their skin. If it's dry and flaky, or when I pinch it up, it tense, it stays up, this patient is probably dehydrated, which means that the plasma is not available for the blood. The water is simply not there. It's going to give me low volume in the vessels, and it's going to lower my blood pressure. Okay. Again, I'm still going to see tachycardia, pale, cool, clammy skin. Well, maybe not cool. This may be hot. And I'm going to see increased respiratory rate. Okay. In addition, I may see these signs. Okay. So with our bleeding, okay, if I have a patient that is bleeding, we're looking for narrowing pulse pressure. So if the systolic and the diastolic, as I'm trending my vital signs, if the diastolic and systolic start to get closer together, let's say the first time you take it, they are 40 millimeters of mercury apart. Okay, so I've got 100 over 60. Okay, and the next time I take it, they're only 34 millimeters of mercury apart. I'm starting to see that get closer. That only time you will see that is in hypovolemia. So that's a really good indicator if we're looking at a type of shock and we notice that trend. Another thing we can do is dissect that and look at if I subtract my diastolic, the bottom number, from the systolic, the top number, and my remaining number is less than 25% of my systolic, then that is a narrow pulse pressure. I'm going to start to think hypovolemic shock with that one, okay? Check your textbook out. That explains that in more detail. Distributive shock, okay? Basically, this means my vessels are the wrong size. They're dilated, okay? This can happen from 3 reasons. First one, this is the one we may consider in a trauma, is a spinal injury or neurogenic shock. The specific sign I'm going to see for neurogenic shock is below the site of the spinal injury, those vessels are not going to be constricted anymore. Even though the brain says we're in shock, we're going to have vasoconstriction to keep the blood pressure up, because the spine is severed or damaged, all of the muscles below that aren't getting that message. And so, like anything, if we're not being told what to do, they just relax, which means those vessels below the spinal injury get big. Now, we see pale, cool, clammy skin when we have vasoconstriction. So we will see that above the injury site. But below that, those vessels are big. And they hold a lot of nice, warm, red blood. So that skin down there is going to look pink and warm. The problem with this is that big vessels drop the blood pressure. And so those big vessels in the lower limbs start to become a pooling place for the blood, which means it's very hard to get the blood back to the heart to be reoxygenated and circulated back around. So because of that low blood pressure, these patients will move to decompensated shock very quickly. Okay, but the big thing we're looking for is there is a mechanism of injury, and we see that warm red skin below the injury site. Okay, a couple of other things that can cause our vessels to get big. One is a severe allergic reaction called anaphylaxis. It's a swelling in the upper airway. We'll cover that shortly. But in that swelling in the upper airway, sometimes we see swollen lips, swollen tongue, swollen face. You will hear stridor if they're breathing at all, and they will have extreme difficulty breathing because their airway is swelling shut. Part of that allergic reaction also causes massive vasodilation, which means the vessels are going to get huge, the blood pressure is going to tank, and even if we get this airway open, we're not going to have a blood pressure to carry oxygen. So that is a biggie. That is a huge life threat if you've got somebody with that reaction. So we'll talk about the treatment for that. But just to right now to understand, this is a form of distributive shock. It's called anaphylactic shock, and it causes the vessels to get huge. Okay, and the third one is septic shock, and that's caused from an infection. Okay, typically these patients don't get sick and move into shock, in a few minutes. Typically they haven't been feeling good. They've got an infection somewhere. A big indicator of an infection is a fever. So if these people have hot skin, or they've had the chills, or they have a fever, I'm going to start thinking infection. Okay, the only time for most cases that we ever get an infection is when or a fever is when there's an infection. And system-wide infections can cause sepsis, which causes a production of lactic acid, makes the vessels leaky, the plasma leaks out, the vessels get big, and we lose the blood pressure. And that's what makes sepsis so dangerous, is that loss of blood pressure. In all 3 of these, the vessels get huge. Okay, that is distributive shock. Okay, again, we're always going to see tachycardia, increased respiratory rate, and signs of vasoconstriction, where the body can. Okay, in neurogenic shock, that will simply be above the vessels. In anaphylaxis and sepsis, we may see it initially as they start into it, but we're going to lose that pretty quickly because the vessels will get huge. Okay. And then lastly, obstructive shock. Now, obstructive means there is something that is blocking the blood flow. Okay. Most of the time, guys, this is caused by a pulmonary embolism, which is simply a clot in the blood vessels, the artery, pulmonary artery. Whoops, hang on here. In the pulmonary artery that is taking the blood to the lungs to get oxygenated. Typically, this blood clot comes from someplace else in the body, moves to the heart. The heart pumps it out through the pulmonary artery because that's a big vessel. And as that pulmonary artery starts to get smaller, that clot gets stuck, which means blood cannot get to the lungs to pick up the oxygen. Now keep in mind, the lungs are clear. Okay, there's nothing obstructing airflow. It's only obstructing the blood flow in the pulmonary artery, but it keeps the blood from getting oxygenated, and it can be deadly. Okay, so in a nutshell, because I'm keeping this short, your thorough assessment is going to help you be able to rule things out and look for those specific signs that you would see in those various types of shock and be able to take you to the right pathway. So take a really good, thorough assessment. Don't ignore anything that you're seeing, and then ask yourself, can I rule out any of these? Okay, so if I know I have crackles in the lungs, bleeding doesn't cause that. This probably isn't hypovolemic. Neurogenic shock or big vessels don't cause fluid in the lungs. So I'm going to be able to say, oh, but heart failure does. So then I'm going to head that way. So your thorough assessment is critical in figuring out what this is and what stage you're in. Okay, so keep it simple. You guys got this. Talk to you soon. Have a great night.